Morning, my name's Dr. Carmel Smart. I'm a paediatric diabetes dietitian at the John Hunter Children's Hospital, Newcastle, where I've worked for the past 25 years with families of children with type 1 diabetes. What I'm going to be speaking about today are the nutritional challenges and some of the possible solutions that families can use to manage their young children with type 1 diabetes. Young children with type 1 diabetes can be a really challenging group around meal times because they often food refuse, or alternatively they may spit out the food or they may fail to finish a meal. And that, as you can imagine, is very challenging and can be very frustrating for parents when they're told to give insulin prior to the meal. And parents thus, and health professionals, can have a fear of hypoglycemia. So what I'm going to be speaking about today are strategies that parents can use that we've used in our clinic, where our children achieve a mean HbA1c of 6.4%, and other means such as mealtime routines that we implement in our centre, where we teach children to eat regularly over the day, so to include breakfast and lunch and dinner with very small mid-meal snacks. And the reason why we do that is because that enables parents to be able to more predictably feed their child, because their child isn't just grazing all day, and it also stops a constant postprandial hyperglycemia. Parents also very much worry about not just about lows, but they also worry about postprandial spikes that they can see on their continuous glucose monitoring traces. And we help parents deal with that by giving them advice around including mixed meals, such as including protein with a meal to dampen the postprandial spike, and also making sure that the carbohydrate content in the meal is of good quality, so low GI carbohydrate, not really quick-acting carbohydrate that will result in very high blood glucose levels after they eat. From diagnosis, what we really encourage parents to do is to go over with the dietitian in the team appropriate amounts for the child to be eating, because often, particularly now, parents don't have extended families, so they may not realise what is an appropriate amount of food for a very small child. And sometimes when children are first diagnosed, particularly, we find they've got very large appetites, and in a 2-year-old they might be demanding very large amount of foods like 45 grams of carbohydrate at a meal, which is not age appropriate. So firstly, we encourage them to go through with the dietitian what is an appropriate food quantity, so that they're not giving really large insulin doses in anticipation of very large carbohydrate amounts. What we also talk to parents about is the fact that the studies that we've done have shown that if the child does fail to finish a meal, it needs to be in excess of about 10 grams of carbohydrate that they fail to finish before any substitution needs to occur. That small amounts of carb, between 5 to 7 grams of carbohydrate, will not, in most children, cause any degree of hypoglycemia after the meal. So the parent can feel more comfortable if the child eats some but fails to finish, say, half an exchange or 5 to 7 grams of carbohydrate. Other things are avoiding filling the child up between meals on protein foods, avoid filling them up on very small amounts of carbohydrate foods, because then the child won't be hungry at the meal time. So the basics is really the Ellen Satter model of child feeding, where you're trying not to allow the child to eat between a meal time, that you remove the food within 20 minutes to 30 minutes after offering. So once upon a time in our clinic, say 20 years ago, we used to have very small amounts of food available all the time to match the insulin amount. Now what we do is remove the food after 20 minutes, and studies clearly show that children don't eat much more after 20 minutes. We remove the food and then leave it 2 to 3 hours, at which time the child is then offered another snack. Very similar to what they do in childcare centres, and childcare centres actually are fantastic role models around what is a good way to feed very small children. Yeah. So in our clinic, we very much work as a multidisciplinary team. So when we're seeing a young child, it will be the diabetes endocrinologist the diabetes educator, the dietitian and our social worker, we actually all see the child together with the parent to make sure the parent gets a common team message. And indeed in our hospital, the ward nurses are also really important at implementing that message as well, so that the family don't get confused messages from the team. If they are concerned, I would really encourage them to talk to the diabetes dietitian in the team if they have a good relationship. It's really who they have a good relationship with that they can work with. The other thing that's been so valuable to many of our parents is continuous glucose monitoring, because what it enables the parent to see the fluctuations in blood glucose after the meal, and it will alert them to the fact that, maybe if the child does undereat at the meal, 2 to 3 hours later, it might be a time to offer the child something else in order to avert them going low. The other thing that our parents actually commonly do is if the CGM is indicating that the child is rising prior to the meal, they'll often get the insulin on board and wait 15 to 20 minutes and to see the arrow going down before they feed the child. So many of our parents are, I guess, now as concerned about the highs as they are about the lows, and CGM is a really valuable tool to enable parents to deal with that well.